Good afternoon. I'd like to welcome everyone to our webinar today. This is Dr. Marnie Peterson. I'm the Outreach Coordinator for the Antimicrobial Stewardship Project, which we launched last year at the Center for Infectious Disease Research and Policy at the University of Minnesota. It's my pleasure today to welcome you to today's webinar, which will include discussion with Dr. Debra Goff about her recently published manuscript, an automated pharmacist-driven initiative that improves quality of care, Staphylococcus aureus bacteremia. This article was recently published in the journal Clinical Infectious Diseases. We're highlighting this journal today with our guest author because it reflects the ability of pharmacists to have impacts on intervention and stewardship using electronic medical records without increasing their resource demand. A little bit of information about Dr. Goff. She is a clinical associate professor at the College of Pharmacy and infectious disease specialist and founding member of the Antimicrobial Stewardship Program at the Ohio State University Wexner Medical Center. She's an internationally recognized expert in the field of antimicrobial stewardship, and she has published numerous articles that reflect her work with other global experts. Importantly, she also has an interest in developing technology applications that focus on treatment of infectious diseases, antibiotic resistance, and antimicrobial stewardship, and she will be discussing some of those applications today with her manuscript. A little bit of information for our participants about our webinar today. We encourage you to submit questions and comments during Dr. Goff's presentation, and that is in a chat. You can do that in a chat box located at the bottom right corner of your screen. We also will have quite a bit of time at the end of her presentation for question and answers, and we really want to increase engagement with our participants and with our guests today. And so you have the capacity to engage using your audio capabilities with WebEx by clicking the hand that's in the middle. On the right-hand side, there's a hand icon. If you click there, it's the raise hand icon, and we'll be able to unmute your line, and you'll be able to engage audibly and verbally with us today. So we encourage you to do that as well. And just a reminder that this webinar is recorded, and at the end of this webinar, which will be an hour long and will end at 1/4 the hour, there will be a follow-on 30-minute Twitter chat where you can engage more with Dr. Goff about other electronic medical records and other approaches to antimicrobial stewardship. So with that, I'd like to thank you for joining us today and welcome Dr. Goff.
Thank you so much. This journal club is meant to be interactive. I hope you've had the time to read the study that we published in Clinical Infectious Diseases, but I'll be reviewing the highlights and then opening it up for discussion, and then followed by a live Twitter chat, which I hope you can participate in also. So let's start. The title of our paper was an automated pharmacist-driven initiative, improves quality of care for Staph aureus bacteremia. And I have to acknowledge the co-authors. Both Eric and Faye were PGY2 ID and IT residents, and this was their major project and really could not have accomplished it without them, along with the IT support of Dr. Pryor and Mellett, and then the infectious disease expertise of Dr. Mangino and Bauer. So a really great collaborative effort marrying the expertise of IT and ID, kind of a catchy little approach. So we're going to go through this issue, why we chose to study this, what our rationale was, how we designed the study, what our main outcome was, the primary conclusion, our limitations, and then open it up for discussion. So our objective was to evaluate the impact of an automated pharmacist-driven targeted initiative for all patients with Staph aureus bacteremia at the Ohio State University Wexner Medical Center. So how did we come to this study? We knew through various years of really following our patients with Staph aureus bacteremia that every patient was not being managed optimally. And so we challenged ourselves, could we do better? We should can do better. And the challenge was, how do we do better? Do we mandate ID consults? So that just was not an option here for various reasons. So we moved then to, could we incorporate pharmacists to manage staph bacteremia 24/7? So as stewardship develops in a hospital, you need to explore ways to maximize program efficiency. And I think that will generate a lot of discussion as programs become more mature and you take on more responsibilities. You have to learn how to incorporate the talent of all your pharmacists. So how can technological advances such as the electronic medical record and clinical decision support systems allow stewardship to deliver more efficient patient care? And that's really what we looked at here at Ohio State. We have an amazing team of IT pharmacists along with our hospital IT department, but we're fortunate to have really an outstanding group of IT pharmacists. And so we worked to try to incorporate health informatics that allowed us to more seamlessly integrate the data from the various sources to optimize our patient outcomes. So this was a retrospective quasi-experimental study of all adult patients with Staph aureus bacteremia. So our pre-intervention period was from January to March, followed by a post-intervention period. And you can see the exclusion criteria that we have listed there. If they had received a prior ID consult prior to their blood culture, they were excluded, or if they were transferred with staph on admission, or if they were discharged prematurely against medical advice. So in the pre-intervention, we have done rapid diagnostic tests, which we've published our results in previous publications, using, at this point, the Verogen gram-positive blood culture assay. In the initial reporting, lab personnel identify a physician within 10 minutes, and that's consistent in both interventions. That's a standard of care here. But we provided to clinicians for the diagnosis and management of Staph aureus bacteremia our evidence-based practice guidelines. And then stewardship on a case-by-case basis with really no formal system-wide process to actively promote Staph aureus bacteremia quality of care. So that was kind of our standard pre-intervention approach. And this is a very busy slide, but it's basically our guideline on management of staph bacteremia. But the challenge, as it is in many hospitals, if the guideline forces the clinician at the point of prescribing to leave the EPIC or Cerner system, whatever one you're in, to go look at these guidelines, it simply just doesn't happen. They have to click out of the system. It makes it challenging, and it's a lot to read. So the guidelines are there. Does everybody use them? And the answer would be no. But that's what our guidelines were stated. So in the post-intervention, we now changed it that pharmacists, all pharmacists, not just stewardship, infectious disease trained pharmacists, all pharmacists on all shifts 24/7 received notification of a patient's blood culture that turned positive for staph. So it was service-based pharmacists were notified of the blood cultures for gram-positives every 15 minutes using this patient scoring tool that our IT team developed. This was developed by the project team, which consisted of the 3 informatic pharmacists and 2 infectious disease trained pharmacists. And every pharmacist on every shift was required to review this patient scoring tool at least once during their 8-hour shift. And all patients were evaluated. Verbal and written recommendations were provided to the treating physician via the electronic medical record. So here's the data that we obtained. The age, sex, hospital service, comorbidities, and our primary outcome was overall compliance and adherence to the Staph aureus bundle of quality of care components. Did they get an ID consult? Were blood cultures repeated? Was an echocardiogram ordered? And did they initiate staph bacteremia targeted antimicrobial therapy? And we also included the time to initiation of the targeted therapy based on our guidelines here at Ohio State. Secondary outcomes were time to pharmacist intervention, the duration of bacteremia, hospital length of stay, infection-related length of stay, 30-day readmissions, and 30-day all-cause mortality. So we had 123 patients screened. 38 were excluded because they had prior ID consults or they were duplicate encounters. So we had 45 in the pre-intervention group and 39 in the post. So demographically, the two groups were well matched. The source of staph bacteremia, most were catheter-related. MRSA accounted for half of the episodes. 2/3 and 3/4 of the staph bacteremia occurred were community acquired in the pre and post-intervention group, respectively. And here's really the bottom line. The initiation of targeted antimicrobial therapy occurred 40 hours sooner in the intervention group. So we went from 84% compliance with targeted therapy to 100% with a pharmacist-managed program. We were able to increase the infectious disease consults from 75% to 95%. Repeat of blood cultures from 95% to 100%. Ordering of echoes was about the same, but mortality was 6-fold higher in the pre-intervention group. So by compliance with a bundle, mortality went from 15% to 2%, which was significant. So overall compliance with the 4 metrics in the staph bundle went from 68% to 92%. So operationalizing the management of staph bacteremia through pharmacists 24/7 with guidance by infectious disease trained pharmacists and physicians improved the overall management of our patients at Ohio State. So you can see some of the other clinical outcomes, such as the duration of inpatient antibiotics in the pre and post, duration of therapy, length of stay, infection-related length of stay, and 30-day all-cause mortality and 30-day readmission, how they differed. So we conclude this automated pharmacist-driven initiative significantly improved adherence to quality of care components for our patients with staph bacteremia. It resulted in a significant increase in the number of patients receiving an ID consult. Notice it does not say mandated, so that's an area that we'd be happy to discuss in more detail. And the number of patients receiving targeted antimicrobial therapy, the most effective therapy based on their history for their staph bacteremia. But I think really what is most significant about the process is we accomplished this by leveraging our frontline pharmacists without additional antimicrobial stewardship efforts. So yes, we have a stewardship program, but as everybody realizes, in a 1,400-bed hospital, you cannot review every patient every day on every antibiotic. And that's really what our very mature program has realized. We have to leverage our frontline pharmacists and incorporate them into our initiatives. And that, to me, is something that is really quite novel and new. And this was only able to be accomplished with the help of our IT pharmacist that allowed us to develop these specific screens and help us integrate the flow of data from a lab-based result into the EPIC system and working with the limitations, because we don't have added on clinical decision support tools. We are working strictly within our EPIC system with the customization by our IT team. So some of the limitations, it is a retrospective design, a smaller sample size, and it is a single center. Pharmacists were only required to review the scoring tool once per shift. We didn't record the amount of time that was required for them to make the interventions, but I I assure you, if it was excessive or intrusive, we would have heard feedback immediately. So our pharmacists really, did not feedback any negative issues about excessive time management to participate in this, and really were quite receptive to being part of this initiative. There were some disparities noted in some of the clinical endpoints, some that were not statistically significant but might be due just to our small sample size. Because this really was a big difference in how we manage an infectious disease here, we wanted to see if we were making a difference in operationalizing it, that logistically it worked, and therefore that's why we chose a shorter study period time. So I think some of the most important take-home messages, it really is the first study to demonstrate the impact of an automated pharmacist-driven initiative for the management of patients with Staph aureus bacteremia, which is really one of the most catastrophic infections if mismanaged. Finding that you can show that pharmacist engagement, and again, these are not infectious disease trained pharmacists, these are not stewardship pharmacists, these are all of our pharmacists at Ohio State. So we can engage them via the electronic medical record, and this can really serve as a framework for providing more efficient, impactful, and disease state-based patient care for Staph aureus bacteremia. So, we believe that this model can be applied to other diseases and not really just limited to infectious disease-related issues. So we think with a good IT support system that you really can engage the IT experts to help operationalize management of diseases. Our focus, obviously, are infectious diseases, but we think this process has application to really operationalize many complicated diseases throughout a healthcare system. So with that discussion about how we did the study, I really would like to engage our audience, as it is a journal club, in a Q&A. So I'd like some of our audience participants, and we have many on the line, does anyone want to comment on our process or share if they are currently using a similar type of process, engaging the entire pharmacy department 24/7 through the use of informatics and customized screens as we presented in this presentation. So Marnie, I will see if we have some hands up or any questions from our large participation group here.
Yes, Debbie. So we do encourage those on the participants that are on the line to just click the icon in the middle, the hand icon, and that way you'll be able to share your experiences and what's happening in your healthcare institutions related to your stewardship programs and how you utilize your electronic medical records. Debbie, I do have a question and I think the participants would benefit, is to talk a little bit about the tool you developed, and then how were the pharmacists notified? I know you say it was through the electronic medical record, but did they have to be online to be notified, or was there a way they were notified as they were rounding in the hospital?
Okay, so every pharmacist had to, so they're not notified via a text message or their cell phones. They each had to log in onto their system, onto our system, Epic, once during their shift to see if there were any alerts that our IT experts developed. And so that created a scoring system. So if you had a positive blood culture for Staph, that created a score, which we randomly assigned, of 500 points. So every pharmacist in their sort of in-basket on Epic would have an alert that there was a patient with a score of 500 points, and that they had to check once during their 8-hour shift. They could have checked more more often than that, but that is actually how they were alerted. So when they saw that alert, then they would click on it, and that would engage them in the process. And I'll tell you that linking the culture positive report from the SunQuest lab system into a manageable workflow took the IT experts several weeks to get that to actually work. So that was a very hard, I'm not an IT expert, but they told me that was actually much harder to develop how that alert would actually be listed, and was quite challenging. So now that they've identified how to do that, if we were to do a second type of initiative, the workflow for IT would be less man hours than it was, but it actually, from their perspective, was a little bit harder of a challenge than they had initially anticipated.
Okay, yes, thanks, Debbie. And then can you just, I think we have some questions coming in as well, but I would also like to hear, it appears that you also had some processes to streamline. Once they got the notification, then they were able to then make recommendations directly into the chart of the prescribing practices.
Right. So I think a big part of our success was that we had the clinical framework in place in the electronic medical record. So that allowed us to just insert these Staph bacteremia checks into this process. And that was really a collaborative effort of pharmacy leadership, pharmacy IT, along with infectious disease pharmacists and our frontline pharmacists all being part of this process. So having that structure available to incorporate these, I think really allowed for the smooth rollout of this project and having our entire staff be part of this. And, you know, that took a lot of upfront discussion and education by ourselves as the investigators, and really assuring the pharmacist that in following the guidelines we created would make meaningful impact on patients, and it actually did.
Did you also have I see that, you know, the ID consults also went up in your intervention period. So did you also have collaboration right along with the ID physicians in this process?
Absolutely, yep. So obviously to have pharmacists managing Staph bacteremia could be perceived as a bit of an overreach in our profession, but we absolutely worked with our infectious disease division and actually presented this to them first, requesting that we move to mandate ID consults for every Staph bacteremic patient. And logistically, it just was not an option at the point of the research start date for numerous reasons within our infectious disease division. And I will say it's a little hard to advocate a required consult when, you know, they're directly compensated for those consults. So there's a lot of political barriers to cross over to mandate consults of a specialist in a hospital setting. And then just the man hours that were required were a bit of a challenge. So we said, what if we try to operationalize this within our pharmacy department, of which they were very supportive. But the actual management in the 4 bundles that our pharmacists were going to be intervening on absolutely had the infectious disease division's approval, along with our medical staff P&T approval prior to implementing this. So the medical staff approved the process, and I think that just reflects on the level of practice that we offer here as to why this was received with the blessing of the medical staff. So in some hospitals that might not be as well received, but I think when you are able to demonstrate that you can perform at this level of practice. And the pharmacist here, we do have a credentialing process for privileging our pharmacists in different areas of specialty, of which infectious diseases is one of them. So that, that years of infrastructure and acceptance of the level of practice by pharmacists here, I think helped support the success of our project.
And also a way it seems that you could very rapidly utilize the laboratory diagnostic procedures that the data's coming out and you're able to then act on it more rapidly.
Right. So, one of the strengths of our program is we were one of the early adapters of rapid diagnostic tests. And I think, obviously this would not have been as successful if we had the traditional way of just being told you have gram-positive cocci and then you wait 4 days to figure out if it's Staph methicillin-resistant, Staph aureus, methicillin-susceptible Staph aureus, or Staph epi. So by having a rapid diagnostic test, once there's growth in the blood culture bottle, which is about a 24-hour waiting period, within an hour we know what the organism is and can direct therapy. Is it going to be vancomycin, or do we need to move to cefazolin, nafcillin, daptomycin, or others? So, that's where we were able to make a significant difference in the time to effective therapy, and that's really driven by the advancements that are in our microlab with rapid diagnostic tests. And again, it shows why a rapid diagnostic test has a meaningful contribution to the improvement of care in patients with Staph bacteremia. So we'll always be an advocate for rapid diagnostic tests because it actually does make a difference in the care of patients. But as our study shows, you need to have a system in place. Otherwise, that rapid diagnostic test results in no rapid change if you don't have a system in place to act upon the results. And again, that's what we were able to show with a operationalized approach, incorporating every pharmacist on every shift. We were able to translate that into meaningful improvement in patient care.
A question that's coming from one of our participants is, did you run into any resistance as you were trying to incorporate all of your pharmacists, even your night shift pharmacists, in this process? And how'd you deal with that?
That is no. I would say not resistance, but inquisitiveness and really just reassuring that we had prepared our medical staff to have notes and phone calls from pharmacists that weren't ID trained and that they were educated prior to the launch of this to understand it. So I think that was our primary role, is good communication with our entire pharmacy staff and assuring them that we were there to support and guide them if they had any questions. And, Carrie Bauer and Eric Wentzler were really the leads in that day-to-day communication, and that's called knowing and trusting the steward. Both of them, and including myself, are trusted and engaged with our department. And so the pharmacists feel that they can reach out and ask questions, or if they wanted a little more one-on-one discussion about that, because recommending echoes and making sure those are ordered is not something a night shift pharmacist is going to be used to doing, nor many of our pharmacists. So I think it was really their ability to stay very connected to our staff, and because they are trusted, the staff really felt comfortable following their lead. And that, to me, is a very key component. You can't just send a memo or tell people you must do this. No one likes to be told they have to do anything. They have to understand the why. And the why was every patient is not managed optimally, and we can do better. And this is why we think we can do better, and this is how we're going to do it. And, you know, when everybody realizes they have an opportunity to improve patient care, you're never going to get pushback, and we didn't.
Were the physicians also notified of the results of the diagnostic tests right along with the pharmacist, or was it something where only the pharmacist on service being notified?
I'm sorry, Marty, ask that one more time.
The results of your diagnostic assay and the scoring system, were those notifications only being sent to the pharmacist on service, or was it also to the attending physicians as well, if it was coming to Epic?
Yes, that's a great question. No, the physicians are our policy for years. When a blood culture turns positive, the physician or nurse is notified within 10 minutes of the culture turning positive. So that's always been done. And every patient is not managed optimally with that process, and that's why we moved to a different process. So they have always been notified. But when you don't exactly know what to do with the result, you don't do anything with it. And so that's part of the problem. That's why we knew we could do better. Something else I want to add is our third shift pharmacist, we're already using the overall patient scoring framework, and the Staph bacteremia initiative was just an additional check to their existing framework. So again, our IT infrastructure here really allowed for the success of this project. And again, all of our pharmacists are very engaged in our initiative. So I think that I just need to make that clear. It's not like we were starting from ground zero with our IT pharmacist or our pharmacist overall. We are a more advanced program, and all of these years of effort, I think, came together into this project, but it's not really the first IT initiative done here. We have a very strong program, but this is the first one where pharmacists have been managing a disease through the skill of IT, helping us customize this.
One thing that I think is terrific, Debbie, is that at the end of this period, Dr. Bauer, Dr. Wensler, and yourself and your other co-authors put this together as a publication. And so, you know, a piece of this is the research component where you disseminate your findings not only to those of us outside of your institution, but I'm curious as to what was your follow-up within your institution? Did you share the results with your other pharmacists, with your administration, those types of groups?
Yes, great question. So, you know, a lot of times we only meet to hear things that are problems, and it gets kind of discouraging. And so this was truly a celebration. So we did do a group presentation 2 weeks ago to our entire pharmacy staff on the impact of this research project. And what's even just so more rewarding is we actually have two publications from one study. So both of our PGY2 residents, IT and ID, each have a publication. So Dr. Wensler is the author of the CID paper, and Dr. Wang is the author of a paper just accepted to AJHP on the logistics of the IT component of it, what they had to do to have this work for us. So it's really, to me, the ultimate home run in a research initiative to have two papers, one discussing the IT aspect of improving our patient care, and the other, the clinical aspect of being able to incorporate this. And, you know, again, it's a great example of how IT plus ID collaborated together, and one could not have succeeded without the other. So to me, I think we can just continue to duplicate this concept, and I would certainly hope others follow our lead and utilize this in their own system. So it's been, and to me, you know, if you don't publish your work, it only helps the patients within your own hospital system. And to me, that's a big disservice. When you find something that works, our goal is to share it, because when you publish your work, you basically put it out there for the world to learn from, and that's how we advance medicine, and that's how we advance our profession. And so, you know, publishing to me is very important. I kind of teach my residents, if it's not published, it never happened. So I think we have an amazing opportunity here because of all of our resources to be able to implement something like this. And that is our obligation, is to try to publish the work and share it with others. And it's a way that I often get many ideas from other great people who publish their work. I look at it and think, that's a great idea. We should be doing that and implement that. So to me, you really have a social obligation to put your work out there. And we did it ×2. So it was a great team effort. And I think hopefully the papers will help others to follow this lead. And ultimately, patients win from something like this.
Absolutely. And questions come in from one of our participants, and I do encourage all of our participants, if you have a question, now is your opportunity to engage with Dr. Goff. The question was, does your facility have any automatic ordering protocols? So can your stewardship pharmacists potentially order cultures, surveillance cultures if they've not been ordered, or other drug concentrations, drug trial concentrations? Do you have anything like that in place?
Right. So therapeutic drug level monitoring, yes, our pharmacists can initiate those orders along with monitoring of creatinine. So our specialty pharmacists are credentialed at Ohio State, which does give them the ability to order certain things within their specialty. So that is a level of practice that's a little different from other hospitals, and that actually is fully described in an HHP article last year by Tricia Jordan and others, describing our credentialing process. So there are a couple other hospitals that participate in that type of credentialing that does afford pharmacists to go sort of beyond the scope of monitoring drug therapy, but actually ordering labs. And then in terms of our patient scoring system and outcomes, our past resident also published a paper in HHP describing that in more detail. So we show outcomes responding to pharmacokinetic level monitoring, and that author is Andre Harvin. So those are two other papers published from OSU clinicians and IT describing that type of practice here. So yes, we do have some ability to go beyond what some pharmacists would perceive as their normal role.
So, Debbie, this is viewed as a success. So is this program continuing?
Absolutely. So this is ongoing. This is not something we implement as a one and done. Because remember, we're in a teaching hospital. So in one more week, we will have a whole new group of physicians in here. And does that mean they know how to manage staph bacteremia? The answer would be no. So the process doesn't stop. It's something that is ongoing, and it's become standard of care now. So it really has taken, the profession of pharmacy to a different level. I think we're incredibly proud to have our infectious disease colleagues support a pharmacist-driven initiative to manage staph bacteremia. And I think it's just so important because around the United States, there are not ID physicians in all U.S. hospitals. And actually, it's a dying profession. The number of physicians specializing in ID is continuing to decline every year. So I think, pharmacists have a very unique opportunity to embrace this and get involved and participate because many hospitals do not have the expertise there. So, I think it's a great opportunity for the profession of pharmacy to step up and contribute in a meaningful way to the management of a disease that, if left mismanaged, leads to just catastrophic outcomes.
So I assume you're working on other diseases, other infectious diseases? and marrying your diagnostic tools with that. Can you share a little bit about what you think would be other?
So in the live Twitter chat that will be following soon that I hope people can join in, I have some links to other places that are doing IT plus infectious disease-related initiatives successfully. So I'll be linking to a group of hospitalists that have initiated with their IT experts in their hospital setting the management of C. diff. And it's really quite an interesting initiative, sort of similar to ours, but being led by hospitalists. So again, I think there are many opportunities. You just really need to find dedicated IT experts that are willing to work on these initiatives. And I think when you bring them to the table face to face to show how their skill changes the way we manage patients, it's very easy to engage people in something that can be as powerful as this. When you can show mortality benefit by managing patients more effectively, that's why we do what we do. So that generally is not a tough sell. But again, IT, just like everybody else, has many competing interests. But, you know, the medical staff clearly knows a great initiative when they see it. And so, you know, we have to sell people on the idea and the concept, and then you bring all the right people to the table and you can really make a significant difference.
You mentioned the importance of having a clinical framework in place with the electronic medical record before you could do something like this. So what other, I'm thinking of gram-negative infections or pneumonia or urinary tract infections. Are there other clinical frameworks that would be in place that would be the next infectious disease that you could focus on?
You know, right now we're in discussion of what is next. So again, it's going to be dependent on your own hospital's approach to managing things. So we have a fairly high incidence of candidemia. Now, other hospitals might have 2 candidemic patients a year, so that would not be a high priority project. That would not be a good use of IT's time to develop customized screens and all that for something that's going to impact a handful of patients. So, you know, I think the application that is a high priority is management of C. diff. So, you know, to me, the best approach to C. diff is to prevent C. diff, not manage it, but prevent it. So what if you could identify all pharmacists on all shifts, you know, things that we know increase the probability of acquiring C. diff. So if you can operationalize every patient that's on triple antibiotics and a PPI, instead of having pharmacists sort of hunt and peck lists of people on PPIs and sort of hand matching that to people on triple antibiotics, have IT figure out how to create that query to identify them in real time and flag those patients. So to me, that's a high yield project that could be operationalized within the skill set of all pharmacists on all shifts. So that would be my personal bias of where I think the highest yield could be. And then the other are multi-drug resistant pathogens, the gram-negatives. You know, if you're in a center with CRE escalating, you know, we're out of antibiotics for that, so I think that's a high priority. So the volume may not be excessively high, but the negative consequence is excessively high, the spread to other patients. So that's where you really need to talk as a team. Where is the highest priority? What project can have a big impact and a clinically significant impact? And that's where I think the strength of a team comes in, trying to prioritize that.
So, Debbie, can you comment then, if someone on the listening today wants to initiate some sort of similar program and they need to have that first meeting, what people do they bring to that first meeting that would start to form that?
Yep. So you need someone from your medical staff. You need someone from IT. And here, many hospitals have pharmacist-trained IT experts, which, there's PGY2 residencies for pharmacy IT. So if you have a pharmacist dedicated to IT, they need to be there along with the hospital IT person who may ultimately be the one that decides the prioritization of the projects. So it kind of depends how your hospital is structured. So you need someone from the medical staff, someone from pharmacy, infectious disease, stewardship, and someone from pharmacy IT and hospital IT. That's where the discussion starts. And then dependent upon what disease state you decide to target. So let's say it's, ventilator-associated pneumonia. Then I'm adding a pulmonologist or critical care specialist because they're the physician that sees those patients the most. If it's C. diff, I'm bringing a surgeon to the table. So it really depends on which disease you choose to assess as to who, but the core people, a physician, a pharmacist, and someone from IT pharmacy and IT hospital.
That's terrific. I think that's really important. Those first initial meetings where you're getting buy-in, and then you can move forward from there with the plan. So I'm just curious now, for people that have diagnostics in their hospital settings, and they're getting data reported back to them, if they can't implement a full IT system, what are some other mechanisms that you found helpful for you to affect change in therapy or management of patients and utilize that diagnostic information?
So traditionally, when we implemented our first rapid diagnostic test in 2010, we didn't have this IT system in place yet. We literally had the micro lab call us with the results. And so they're obligated to call the physician, but they realized what we were going to do. We were going to act upon the results immediately. A lot of the physicians, when they get that phone call, if it's a surgeon and they're in the OR, they can't act upon it. They're in the middle of a surgical procedure. So I absolutely understand that. But because we're credentialed, we could act on it on their behalf. And again, that they know and trust us. So if the lab calls a surgeon and they're in the OR and says your blood culture is positive for Staph, they're like, let them handle it. And they know what we're going to do, and we have the authority to act upon it based on our guidelines. So, that's how we traditionally did it, and it worked, and it made a big difference. The challenge we have is that was 2010, it's now 2017. We have multiple rapid diagnostic tests. So having the lab call us with every one is no longer manageable. So, we had to adapt as we became more successful and added more tests. Just like every stewardship program will have the challenge as you take on more initiatives, your workload continues to increase, and usually you're not getting more manpower to handle it all. And that's what I think the beauty of our study shows. You have to learn how to operationalize some of the initiatives because you're not going to be handed more resources. So how do you incorporate all pharmacists into this initiative? And I think that's really what we demonstrated.
So really starting to change how all pharmacists practice in the hospital to some degree. And one important point, too, I think is important to discuss here before we end with the participants is it appears that you developed your own guidelines within your healthcare system. You're not necessarily adapting the IDSA guidelines.
Well, that's a great question and a great thing to address. So, of course, we start with the IDSA guidelines. But when you read those guidelines and you get down to specific antibiotic therapy, they kind of give you, well, it could be Vanco, it could be Dapto, it could be, but you need more information. So they're not really if you're a surgeon and you don't know which drug to use, you're not going to find the answer in the guideline because it gives you multiple choices. We drill it down to, based on our data here, this is when you use Vanco, this is when you use Cefazolin and Napsylin, and this is when you're going to use Dapto, because we have our own specific data. So yes, our evidence-based practice guidelines are founded around the IDSA guidelines, but then they're customized and sort of tweaked based on our years of historic data and presented to the medical staff, and then that becomes our policy. So they're actually more sort of black and white. We tell you this is exactly when the patient is going to get empiric daptomycin therapy. You're not going to find that in the IDSA guideline, which I understand why not. They're meant to be general guidelines. Our job is to customize that great guideline into hospital-specific data for our patients here. And that's based on the MIC, their history of staph bacteremia, failure of Vanco, toxicity of Vanco, that make us decide what therapy will be used up front. So, yes, we do incorporate the IDSA guidelines, but we then kind of take them one step further.
And then, of course, this is all incorporated into the electronic medical record, the decision-making tool.
Correct, right. So that's all, they can link right in Epic to the guideline. We found early on, if you make them have to go out of Epic and go look on the OSU website for a guideline, it doesn't happen. And I don't blame them. There's enough screens you're looking at there. If you have to click out and go to another system and log in, it's just the workflow is not conducive and it's not time efficient. So having our guideline embedded right in Epic, again, is the skill of our IT team to make that happen. So if you want to look at the entire workflow guideline, you can do that, or you can just look at the 4 bundle components, and we target that. And so I'll finish with one other comment that I think is important. The notes that our pharmacists would leave in the medical record were basically kind of pre-formatted by IT based on our input. So we gave standardized messages back. So it would be based on the evidence, this patient should receive vancomycin, daptomycin, and each pharmacist just would put in that one term. So everyone's not free texting different types of messages. They're standard replies based on the 4 bundle approaches. So again, those were all scripted ahead of time and taught to our pharmacist. And that was really the skill of our IT team in us developing those answers.
Yeah, that's important and also saves time. I believe we have a participant that would like to actually ask you a question through the audio system, Debbie.
Sure.
Oh, hi. Can you hear me?
I can hear you.
Hey, this is JJ Mellett, one of the authors. I'm one of the IT pharmacists at Ohio State. Actually, more just had a comment. I figured I'd just kind of add a little more background on the scoring system itself, just to kind of really emphasize that I think a big part of the success that we had at Ohio State with implementing this is that we had really deliberately kind of created a workflow in the EMR that involved our first shift, second shift, third shift pharmacists, and it kind of built in a place for them to be alerted of things that they needed to focus on. So patient scoring is the Epic term that they use for kind of this clinical decision support tool that you can kind of if you can dream it, you can build it type thing, where you build a rule, you build a check, you can have those populate in that patient list, and it really essentially is it's like a roster, like a patient list. It adds it's a value of scores that add together. So the higher the score, maybe the more urgently you need to review that patient. But really, even the scoring piece is just one part of it. At OSU, we have the scoring piece to alert pharmacists. We also have the documentation piece where we have, standardized progress notes that kind of guide you through different checklists. So for example, like our bundle items, we had built that into a standardized progress note. So, even if the pharmacists weren't super familiar with every piece of that bundle, when they pulled up that standardized progress note, it kind of guided them through the checks, the things to look for. There's also that communication piece as well as the handoff piece. So the scoring tool is good, but also having a way to indicate that, yes, I've already done that, or I've, if it's a kinetics thing, how do you ongoingly monitor that and also be alerted to things that need directly addressed. So it just kind of underscores the idea that, on the one hand, you can build out a lot of really cool stuff, but if they're just individually siloed, and you'll end up with an endless checklist of things to go through versus kind of coming up with a framework. And, having that framework in place really allowed us to take the Staph aureus bacteremia check and kind of just seamlessly incorporate it, which is why, the education piece was much more directed at, we're reviewing Staph aureus bacteremia, what the bundle is, a little more on the clinical side, and not as much on the operational, like, here's how you do it, here's how you see these things, because, it's stuff that they're already looking at, for third shift. This was something they were already doing. They already, would respond to vancomycin levels, things like that they were alerted to the patient scoring system. So I think to end my really lengthy comment, I guess it just kind of underscores the need for kind of, collaborating with your IT pharmacist to kind of come up with an end-to-end clinical workflow that includes patient identification, communication to prescribers, and handoff communication to other pharmacists. And I'd be happy to answer other specific questions if people have them about a little more of the tool itself and how we set it up.
Thanks. Appreciate that. And again, that's our IT expert, so we could not have succeeded without theirs. And I think what was so great is, we just described what it is we want to try to do. How can we do it? And it was really just a great discussion together to try to make this happen and to see it all take place and succeed, and our patients did better. It was just really one of the more personally gratifying research studies we've done. It was really just an amazing accomplishment. And I think the other part is our infectious disease physician, Dr. Mangino, who was part of this study, who watched for years, people get mismanaged and every physician doesn't consult ID, and that was part of our challenge here, to just see how, we just wouldn't take no for an answer. We can do better. We'll find a way to do better. And we actually did. It's just, it's been a really amazing journey here, and I think many can benefit. I'm going to just finish with the last comment, and looking back at the questions, I see very specifically one pharmacist asking in the community setting, she's getting pushback from pharmacists being asked to do involvement in caring for patients sort of beyond what they're used to. How do you get them to participate? So I would just reiterate, when you ask people to do more work, generally they're not going to embrace it until they understand why you're asking them. So, a lot of stewardship programs just tell people what they can and can't prescribe, and that's where the conflict starts. So when you're asking people to do more work, I would first start with understanding that we have a problem and show them how patients are not being managed optimally all the time. And as a pharmacist or a nurse or a physician, you can help make this better. And the way we're going to do that is I'm going to ask you to become more involved in how we manage these patients. And your involvement would be, and then go on to explain what you're asking them to do. Sort of like years ago when we went to extended infusion beta-lactams, the only person who was not in favor of it was the nurse because it inconvenienced them. But when you show you have an option to make a difference in mortality, will you help us? sort of hard to get a no from that. So a lot of it is the approach, and if you do that strategy approach I just described, I think you'll get a better response from them. But it's a very important question. So I think we're at the top of the hour and need to move to our Twitter chat. So Marnie, if you just want to close it up, and if you have any closing comments, we'll move on to the live Twitter chat, which I encourage you to participate in.
Yes, thank you, Debbie, very much. And also thank you, Dr. Mellett, for coming online and giving us some more insights into the actual tools that you helped to create at your institution. So as I've mentioned, this concludes the Antimicrobial Stewardship Project webinar for today. We appreciate all your questions and your comments, and would like to thank you for your time today. And immediately following this is our Twitter chat, which will be at our CIDRAP ASP Twitter site. So feel free to continue on. And also, this was recorded and will be available on our content tab under our Journal Club content from our website. So thank you very much.
Thank you.